Look, our final speaker this morning is Dr. Sarah Cherian, the General Paediatrician and Clinical Lead of the Princess Margaret Hospital's Refugee Health Service. While the findings of this consultation reflected a very positive experience for most children and young people, we know that refugee and asylum seeker children and young people face some significant and quite specific challenges relating to their background. Sarah will outline the Paediatric Refugee Health Service's role in coordinating and managing the complex care needs of recently resettled refugee and asylum seekers under the age of 16. Please welcome Dr. Cherian.
All right, well, thank you, and it's a pretty hard act to follow. But firstly, I'd like to congratulate the Commissioner's team on a marvellous piece of work that's been undertaken. And I think for us as a service, it resonates so truly with some of the issues that we see in our families. And I guess we see them really at the early end of their journeys. And for us, it's a very big privilege to work with our families as they take that journey into resettlement here in Australia. And I think it's just a marvellous thing that they've been given a voice. So this is my wonderful team, and I'm going to stress that it's multidisciplinary. And our team came into existence now 10 years ago officially. So this is our 10th anniversary in 2016. And it came about because in 2005 we saw an influx in newly arrived families who had many infectious concerns, but also issues that weren't being dealt in a traditional holistic health environment. So our team was established, and over the last decade we've augmented through the use of research and evidence base to build a team of health professionals that include medical and nursing staff, dietitians, social workers, teachers, dentists, and importantly down the bottom, integration of volunteers, language services, and also our wonderful bus drivers who take families to and from appointments. We know that there are many barriers to health and access for these families, particularly in resettlement. We've got over 50 different ethnic groups and language that our families speak, and it changes every year. The intakes you can't predict, and that flexibility within our health service is very important. We also know that the simple task of asking a family to go from our clinic up to the main hospital to get a blood test can overwhelm families, and we've had families who have just gotten lost in Subiaco, making that 500-metre journey. So our volunteers actually take them physically to do these things. Most of our families do not have private transportation. How do they navigate our difficult Perth public transport system to get to Princess Margaret and soon to be Perth Children's Hospital? So integrating those aspects into our service has been a very important decision for us. Having medication on site that's freely available and accessible with on-site interpreters to talk about compliance and safety, ensure that the families understand which child needs which medication, and it's not an added cost or burden, because most of these families are on Centrelink and are very relatively impoverished compared to you and I. Having teachers who can embed and advocate for these children when they make that transition, not only from an interrupted schooling background, but here to the intensive English system, and then again, as we heard, that very big step into mainstream schooling. Some of these children have had medical issues, most have had trauma, and whilst they're extremely resilient, advocating is sometimes so hard for their parents who are battling with day-to-day issues. So taking that into our system is so important to give these families an additional voice. So I'd like to think that occasionally our service does do a good job, and I think we are very quiet. We don't put a lot of press or media out, like the pretty things that the Commissioner has just released. But we are taking this journey, and we are trying to always improve, because we're not perfect. We try to advocate, we try to teach, we try to improve cultural competency, but we're one very small spoke, and you can see all the wheels of people in our community who are each doing their separate jobs. And I think one of the things that I'm very keen about is breaking down those silos, improving transparency, improving communication, and this is a very big step of that process. So what do we actually do? Well, firstly, we aim to provide holistic healthcare. So We assess and we coordinate and manage the complex care needs of those recently resettled refugees. Unfortunately, we see under 16 years of age, but we also see those who are in detention or in the asylum process. And again, this is a very hidden and extremely vulnerable subgroup of this cohort. We, where possible, link to community supports, and our service does not hold on to families, but instead, over the next 6 to 12 months, they exit and transition into mainstream community pathways or subspecialty areas. But that also includes community organisations. We have very big community links with some of our key multicultural service providers. And this is important because health is not just medical, it's the whole of your being. And we also advocate, and I think that's a very big part of what we do. And through our advocacy, one of the big strengths that we use is clinical research. And by demonstrating gaps, providing data, we can then say, this is a problem you can't now ignore. Because part of it is that no one has been doing data or research in this field. It's now blossoming and emerged from the 10 years when I started. And there's also stuff that's going on both nationally and internationally. And I think the Syrian context is something that we can all draw on. There's a lot of research that we can then use to modify what we do with our practices and our service provision. For us, because we see families very early in their journey, it depends on a number of aspects as to what we actually do at that first consultation. And for us, our families are seen as a group, so all the children are seen at the one time, and we also try and link them into our social worker, our dietitian, our dentist, so they're not going back and forth, because for them the priorities are getting access to schooling, establishing their Centrelink, getting their TAFE organised, sorting out their very itinerant housing, worrying with all the drama and the conflict, the trauma that's going on. Health is really not their main focus. But if their kid can't eat because they've got dental issues, we can though sort that problem out and say to them, look, we've done this, you can now focus on those other key priorities for you. Obviously this takes time, so we have a non-traditional, attitude. An appointment for us takes as long as it takes. It could take 2 hours because you've got 4 children, but then you're not making that family come back and forth. Follow-ups may be much shorter, but if at a follow-up a parent comes and tells us, actually my child is really stressed, is not sleeping, I think they've got some trauma issues. Sure, they might have come in for a vitamin D check, but we then stop, we reallocate time, and we be flexible because that's what the families need. So I got asked to talk about what we do, and I guess there's a lot. Every family is different, every child within that family is different. So we have medical issues, infection, we deal with nutrition, growth, undernutrition, obesity as they are here longer and take on a more Western lifestyle. Some of the cultural child protection issues that are hidden in these communities. We talk about education, as I've said before, and also advocacy for the trauma of the children in detention. We do contribute to our national colleagues and some of the other professional organisations in terms of advocacy. And over the decade, we've done multiple different research projects, including aspects on play, and I guess the most exciting one that we're doing at the moment is our adolescent health research, which fits in very nicely to what the Commissioner's been doing with the youth. And we're looking at a series of over 100 adolescent refugee youth, including some of those children who have been through detention, and doing a holistic screening called head screening on them, as well as some other psychological and medical aspects to it. And Kajal Hirani, who is our lead author, is about to present this work at a national conference, but this is going to really be important for us to advocate. We know that adolescent youth over 16 are a hidden gap, and there's no adult equivalent of our service here in Western Australia to take on that burden. But the data doesn't exist for us to advocate. So we're hoping that this really will open up that dialogue, make people take notice, and then start to make some changes. And again, advocacy for those who are vulnerable and sometimes can't vote for themselves. But that's us in a nutshell, because I had to keep it very short and sweet. But yes, I'll hand over to the Commissioner's team.